This portion of our lecture series focuses on the pharmacokinetics of local anesthetics, that is, the absorption, distribution, metabolism, and excretion of these compounds. So how does the body affect the drug after it's injected, and what are the consequences of these actions on the body itself? Regardless of the type of local anesthetic, whether ester or amide, all local anesthetics are weak bases that are only slightly soluble at pH 7. In order to get these drugs into solution, they're dissolved in and marketed as hydrochloric acid, that is HCl salts. When dissolved in acid, the drugs are largely in their ionized or charged state. As the pH of the solution increases to a more basic range, the drug reverts to a greater percent in the uncharged form. We know that the ionized form, that is the cation, is the active form of the drug that can interact with its binding site in the sodium channel. However, it's the basic form, that is the unionized form, that's permeable across the membrane. So in the acidic solution in which they're marketed, they go into solution because they're charged, but they can't cross the membrane. In contrast, the uncharged form fails to even go into an aqueous solution, but crosses the membrane relatively well. However, only the ionized drug binds to its receptor on the inside of the sodium channel. So if only the uncharged form enters the nerve, how does the charged form of the drug in the bottle of local anesthetic that you purchased get into its site of action inside the nerve? There are two characteristics that determine the permeability of the drug across the membrane. The absorption of the permeable form of the drug into the nerve depends on the pH of the local environment and the pKa of the drug. So what is the pH? The pH is simply the concentration of hydrogen ions in a solution. Remember that the pH of the body varies from the very acidic stomach to the more neutral plasma in the circulatory system. Even the extracellular fluid has a pH. So the pH is a characteristic of the solution or body fluid into which the drug is dissolved. And what is the pKa? The pKa is the pH of the solution where the concentration of the unionized drug equals the concentration of the ionized drug. So the pKa is a characteristic of the drug. If you need a review of this, the pKa can be derived from the Henderson-Hasselbalch equation. To illustrate our drug's ionization status at different pHs, we'll compare the ionization of a weak base on the top to that of a weak acid, shown on the bottom of this slide. The x-axis shows the pH from 7 to 12 for a weak base, or from 1 to 14 for a weak acid. Remember that a low pH is acidic, whereas high pH is more basic. The y-axis shows the percent of the compound that's in the ionized state from 0 to 100%. The local anesthetic used in this example has a pKa of 8, so 50% of the drug is in the ionized form and 50% is in the unionized form at pH 8. Remember that it's only the ionized form that binds to the receptor, and only the unionized form can pass through the membrane. As you can see, as you increase the pH of the solution, the percent of the drug that exists in the ionized state, as shown by the red line, decreases precipitously over a short pH interval. At the same time, a greater percent of the drug becomes unionized, as shown in the blue line. We need the drug at a pH where some of it is ionized to bind the receptor, and some of it is unionized to pass through the membrane and reach the inside of the cell where the binding site is located. You'll notice that the difference between a weak base, like the local anesthetics, and a weak acid, that is the anticonvulsant compound shown below, is that the ionized form of the drug is in the opposite pH range. That is to say, more weak base is unionized at a high pH, whereas more weak acid is unionized at a low pH. So if you go into research where your drug is not already dissolved, but simply handed to you as a powder, to get your drug into solution, you need to dissolve weak bases in an acid solution and weak acids in a relatively more basic solution. Let's look at an example using 10,000 molecules of a local anesthetic. As we already described, a certain percent of the drug will be in the ionized form, and the remaining drug will be in the unionized form, depending on the pH of the solution and the pKa of the drug. If we start out with the same amount of drug, but dissolve them in two different pHs, the absolute amount of drug found in the unionized form at pH 4 will be much less than the amount of drug at pH 7. So in our example, only 10 molecules of the drug are available to cross the membrane and enter the cell when the extracellular environment is pH 4 or slightly acidic. However, 1,000 molecules of the drug are available to pass through the membrane at pH 7. Once inside the cell, the drug establishes a new equilibrium based on the pH on the inside of the cell. This pH is relatively neutral and doesn't change as much as the extracellular environment because of the buffering effect of the intracellular proteins. So inside the cell, the percent of drug in the charged form will be greater than that in the uncharged form. Luckily, it's the charged form of the drug that can inhibit sodium channels by binding to a site located inside the sodium channel itself. In summary, only the unionized form crosses the membrane. Only the ionized form binds to the receptor, so more drug reaches the receptor when the extracellular fluid is pH 7 than pH 4. To summarize the distribution of these drugs, we know that they're usually injected directly into the desired location. We know that a low tissue pH impairs the distribution of the drug into the tissue. And redistribution is very important for the duration of action of amide-type local anesthetics. They're not metabolized locally, so redistribution away from the site of injection terminates their action. Another factor influencing redistribution is that co-administration of adrenergic agonists prolongs anesthesia by preventing the washout of drug from the site of action. In other words, epinephrine, phenylephrine, and norepinephrine are able to cause vasoconstriction, which decreases blood flow at the site of injection. With decreased blood flow, there's a decrease in the tendency for the local anesthetic to redistribute to the vasculature and be washed away. Where are these drugs metabolized then? Amides are degraded by dealkylation in the liver, and esters are hydrolyzed locally by acetylcholinesterases at the site of injection in the extracellular fluid, and also in the plasma by pseudocholinesterases. This is because the structure of ester-type local anesthetics is very similar to that of acetylcholine, which is the endogenous substrate for these enzymes. The anesthetic effect of esters is terminated largely because of their rapid metabolism. In contrast, the local anesthetic action of amides is primarily dependent on redistribution back into the circulation from the site of injection because they're not metabolized locally. Procaine and procainamide are great examples of the difference in duration of action between esters and amides based on their metabolic rate. Esters like procaine have a very short duration of action because they're metabolized rapidly. But when procaine is amidated to form procainamide, it's much longer lasting because then it needs to be redistributed from its site of injection to be metabolized in the liver. This is the basis for our ability to use procainamide injected intravenously for heart conditions without it being metabolized away in the circulation as fast as procaine itself would be. The pharmacokinetics of these drugs is very important in their clinical use. Esters are metabolized prior to exiting their site of injection, as well as in the circulation itself. So clinically, they tend to have a short duration of action. In contrast, because amide-type local anesthetics are metabolized in the liver, they're generally longer acting than esters. They're also potentially more toxic than esters because they're present in the circulation for longer periods of time and in higher concentrations before they're metabolized by the liver. One consequence of this also is that the amide-type local anesthetics can't be used in patients who have liver failure. All local anesthetics have an attenuated effect in tissue that's inflamed. This is because inflamed tissue generally has a lower pH. That is, it's slightly acidic. As a consequence, local anesthesia is harder to achieve in inflamed tissue because it's absorbed poorly into the nerves. This ends our discussion of pharmacokinetics of local anesthetic drugs. Stay tuned for the third and final video focusing on other clinical considerations when using local anesthetics.